Good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. We've talked on this program before about America's maternal mortality problem. Too many women, and women of color especially, are dying during pregnancy. Today we're focused on one reason for these preventable deaths: maternity deserts. Take a look at this map and notice the orange wall in the Midwest. It runs right down there like a spine in the country. So the Dakotas, Nebraska, Kansas, Oklahoma, and Texas. Every piece of orange is a county that does not have any obstetrician provider. I'm going to come back to what that means in just a moment. More than 2 million women of reproductive age live in those orange counties. We're about to see what the maternity deserts look like in Kansas and explore the biggest hurdles to improving access. We'll also hear directly from a mom who needed to drive for hours for proper care during her high-risk pregnancies. But first, let's talk about morning rounds. We are celebrating a milestone for one of the health system's most impactful programs. Today, it's called the Care Collaborative. But 10 years ago, it started as a small network of rural hospitals and providers who came together to improve treatments and outcomes. We welcome Jody Schmidt, the Executive Director of the Care Collaborative. Originally, the Care Collaborative was focused on heart attack and stroke. Jody, how did those collaboratives, the collaborative itself, address heart attack and stroke?
We addressed heart attack and stroke in a new method of bringing education to the rural communities, really looking at the evidence-based practice we use here at the health system, turning it into a boot camp and protocols that we could take out into the community. And instead of asking 1 or 2 people to come to us and then go back home and implement, we take the training to them, so the physicians, nurse practitioners, physicians assistants, nurses, EMS, everyone hears the same research, the same best practice at the same time, and then we provide the implementation support. So what we've seen from that is where traditional adult continuing education improves actually leads to change and improves care less than 10% of the time. We have flipped that, and our data has shown that we've improved care more than 90% of the time.
So now this started with 11 hospitals, an independent physician practice, and a health center. How much has the Care Collaborative grown over the years?
Today we have 85 members across 73 Kansas counties. Roughly 2/3 of the state participate in our work.
Holy schmoly, that's a big part. At least there's not a big desert on that one, so that's good. Now, if a rural hospital doesn't have the resources to follow the national guidelines, how can the Care Collaborative help?
That's why we bring those services to the rural community, because we know they have such limited resources. And then we provide support like a tablet in the emergency department for the transmission of EKGs. The stroke team here has a bat phone. Yes, it's called a bat phone, brain activation, so that they can reach out and get guidance and support around an individual patient situation. We also have identified gaps in areas like telebehavioral health, so we have telehealth in 11 of our rural health clinics. We have home-based care. We've done more than 144,000 chronic care management and remote patient monitoring visits where we're actually connecting to patients in their home and monitoring their blood pressure, their blood sugar. Heart failure patient, we're monitoring their weight with cellular devices. So we really work to not just bring the education, but to provide wraparound support through the Care Collaborative.
That's a big darn deal. You know, we're about to talk about maternity deserts in just a moment. Has the Care Collaborative talked about that at all?
We absolutely have, and we've certainly seen the data that Dr. Kennedy and others will be talking about this morning. So we have piloted a project, and we're very fortunate to have Patterson Family Foundation funding to help us test a model of bringing remote patient monitoring to the community of Colby and the 7 surrounding counties for whom they deliver. Dr. Mosier has been working with their medical director around algorithms and protocols so that we can really, hopefully, identify things early. We've seen some situations where a nurse in a local ER that hasn't delivered for more than a decade suddenly has a patient walk through the door. And you don't want to be that nurse that hasn't helped deliver for 10 years and suddenly you're in that crisis situation. So our goal is to really identify these things early and be able to get patients to care sooner because we have such a large geography.
Jody, thank you. Thanks for being here. Appreciate those comments are awesome. They're spot on for this program. But most of all for today, congratulations on 10 years of the Care Collaborative, helping improve the health of Kansans. It's a big darn deal.
Yes,
Thank
thanks
you
so much.
All right, we're going to turn to maternity deserts in Kansas. We have a great panel of experts with us today, and I'm not just saying that because I happen to be married to one of them. At the desk and to my far right is Dr. Bob Mosier, a family physician and executive director of the Kansas Center for Rural Health. He also was really involved in that whole care collaborative thing. Dr. Carrie Winnicke, an OBGYN and clinical service chief and chair of obstetrics and gynecology here at the University of Kansas Health System. Good morning to you both. Thanks for being here. To my left is someone who I know pretty well. She's actually sitting by me today. She had to sit next to me in medical school, and 41 years later, we are right here. Dr. Sandra Stites, an OBGYN, Chief Medical Officer at Vibrant Health, and the person I've been married to joyfully for 37 years.
Thank you.
No comment at all?
No comment at all.
Get anything out of that?
That's a start.
Wow.
That's a start.
Okay, here we go. She's told me this is going to be the one and only time she's going to sit next to me on the program. What would that could mean? Also joining us remotely, Dr. Michael Kennedy, a family medicine physician and rural healthcare expert. And Dr. Mark Parrish, I'm not sure if he's been able to make it down to the program yet, so if he does, all right, there he is. Awesome. An OBGYN with extra training in maternal fetal medicine. I know he had a little clinical work to do this morning. And most importantly, Jennifer Cunningham, a patient who lives in Garden City, Kansas. We're going to hear how she navigated 4 high-risk pregnancies, sometimes driving hours to get to the care she needed. Let's first start with a definition. Dr. Mosier, is a maternity desert defined by distance, by population, by insurance coverage? What is it defined by?
Well, it's really defined a little bit by the distance, but particularly just not having access to maternity care providers within their community or within a 30-minute, 30-mile drive, if you would, or having those services available within that local healthcare system. So we know from a recent study that Chartis did for the National Health Association, the report that came out in 2023, that about 50% of women that live in rural don't have immediate access within 30 minutes or 30 miles of OB or maternity care.
So Dr. Winnicke, talk to us a little bit about that definition. What does it mean to have OB or maternity care? What kind of care providers are we talking about?
Yeah, so this definition outlines it pretty specifically, and it would either be an obstetrician, a family medicine who provides obstetrical care, or a certified nurse midwife. So any of those providers within that region would qualify or take into account if that area is defined as a maternity desert.
And sometimes, Dr. Stites, even in an urban area like Wyandotte County, we can have some spaces where people have a hard time. It may not be 30 miles, but they may not be able to find the care they need.
Yes, and primarily that can be due to poverty. So even in areas where 10 miles down the road there's access, if it's not necessarily perceived as culturally competent, or if the persons don't believe that they will be listened to, they also can be considered a desert, just not having access and not feeling comfortable.
Dr. Kennedy, this is some work you've studied and done a little bit of work on in your career. You've shared a few maps breaking it down county by county. You want to walk us through some of this?
Sure thing. Well, we actually started looking at this, looking at a similar map to your opening map, and we thought in 2013, wait a minute, we know some people who are delivering babies in some of those counties. But when we looked, there was no readily available resource to try and figure that out. So the first map that I provided is a map that in 2013, the blank counties, the white counties there, had no providers for obstetrical services. And that included family medicine and OB. And surprisingly, there are no certified nurse midwives in rural counties delivering babies. Now, they're all in urban and semi-urban counties, but none were in the rural counties. So the white counties there were no, yeah.
Oh, I was just going to say, it looks like there's been a change from 2013 to 2023, but in the wrong direction.
Exactly.
Talk to us about that.
Wrong direction. And so there's a lot of stresses, and maybe some of our panelists can talk about the stresses currently, but all the counties in red are counties that have recently, in that 10-year period, stopped providing OB services, which expanded the maternity deserts. And the ones in orange are counties where the delivery numbers have decreased. Now, some of those are urban counties, and the reasons for that are unclear. And then, interestingly, some of the rural counties have actually experienced increasing numbers of deliveries. But if you look, they're kind of bordering on some of those red counties. So women are going to those green counties to deliver their babies.
So that's a struggle. And I think, you know, Dr. Mosier, you were the dean for a while, the School of Medicine in Salina, and Dr. Winneke, you were the program director for OBGYN for a long time. So guys, people are choosing not to go to those counties. Talk to us a little bit about why that is when it comes to maternal care.
Yeah, from a rural perspective, it's challenging if you go out there and you're the only provider providing obstetrical services, because you're basically on call 24/7. And you may also be limited in the actual number of deliveries that you take and work on every year. So you can have some deterioration of those skills, and that confidence of managing complications goes down over time. And then you've got all of the support staff. You have to have nursing staff trained and comfortable in providing, you know, labor and delivery services and postpartum care. And that's becoming more of a challenge as well. And then finally, anesthesia services. A lot of rural hospitals are served by a certified nurse anesthetist. And if you don't have one there, then that means when an OB patient comes in, you have to call to find out if they're available. Can they come to sit around? And you may or may not use them, but that's an added cost to the local healthcare system. So it's a higher cost driver for providing that service to a lot of rural hospitals, and reimbursement hasn't really kept up to offset or match some of that cost. And so hospitals look at it as a loss leader, and they have to make a decision at some point. What do we do? And if you have providers who aren't interested in continuing to deliver OB, or nursing staff that's not excited about continuing it, and you have an administrator who says it's a loss leader, it disappears, unfortunately.
And I'm just thinking, Dr. Winneke, that the trainees don't want to go to that kind of environment either. That sets the women up in a pretty delicate situation.
Yeah, so this has been a discussion amongst OB residencies and residency programs for quite some time, that, you know, even if we purposely seek out candidates that are from rural areas, a lot of them don't want to go back. I grew up in a town of 2,200, and I'm here in Kansas City.
Field of Dreams. Just say she grew up in the town of Field of Dreams.
Yes. So, you know, there it is. But there have been some changes. So there are now, I believe, 3 programs in the United States that actually have a specific resident to their program, has a different residency number that is a rural program. So they spent 50% of their time out in partnering communities, 50% at sort of the urban academic teaching hospital, with the goal of putting these practitioners back out into rural areas. So Wisconsin led the charge of this, and I believe, if I'm counting correctly, they probably have graduated 1. And I don't know where that provider is out in practice, but there have been some ideas to try to really carefully pull someone in. But that's an N of 1, and that's really hard, because, you know, babies don't listen to us about when they want to be born on a day or during the time of the day. And it's really hard to be on call 24/7, 365. So, you know, an N of 1 is going to help a little bit, but what we need is an N of 50, you know, to put groups of people out in the community.
Yeah, it's a big darn deal. So, you know, we know that this can be very challenging for patients who are delivering. Let's hear directly from a mom who struggled to find adequate care in her community. Here's Alexis Del Cid with that story.
With her sweet smile and rosy cheeks, 7-month-old Camden Cunningham only has eyes for her mama, Jennifer. That is until her 2 big brothers enter the room.
Do this.
And they only have eyes for Camden. Now, normally, Camden's big sister would also be getting in on the fun, but on this day, she's at a play date.
Do we both have glasses?
When Jennifer and her husband chose to build their lives and grow their family, they fell in love with and put down roots in Garden City, the small southwest Kansas town about 6.5 hours from Kansas City. They had no idea at the time that their geographical location would make all 4 of Jennifer's high-risk pregnancies even riskier. But it became frighteningly clear when she was pregnant with her oldest, Brody, 8 years ago.
When I was 35 weeks pregnant, I started having some really bad pain in my left leg. And so I had called them and said, hey, I'm having this really bad pain. And the response it was just, that's what happens when you're pregnant.
So she gave it another week.
People were noticeably saying, why are you dragging your leg? And I'm like, it's almost like it doesn't work. And going into 4th of July weekend, my left leg started to feel really rubbery. So I called the hospital and they said, we don't think that there's any issue.
She insisted on being seen in person, and it's a good thing she was so assertive.
I had an 18-inch deep vein thrombosis in my left leg from my hip to my knee, almost fully blocked. Nurses that had worked for the hospital for 30 years saying, we've never seen anything like this. Can we look at your leg? Can we see what it looks like? And of course, at that point, panic set in.
Her husband took matters into his own hands, reaching out to the University of Kansas Health System, where the medical team here had an urgent message for them.
You need to get here tonight.
They got in the car and made the 6.5-hour drive across the state, where Jennifer wound up staying in a hotel near the health system for the next 3 weeks until giving birth. Very stressful, very expensive, and the only option to be near experts who could care for her. While the birth of her first was the most complicated, the following 3 were also high risk with special circumstances, and each of them required resources and care no longer offered in her hometown.
By the time I get pregnant with my 4th, there's 1 OB left in Garden City, and we're not getting any more. No one's coming to do the maternal fetal care for moms in Garden City. They're seeking out doctors in Wichita and Kansas City and wherever they can to get that care.
Jennifer, we're glad you and the kids are healthy, and thank you for being on this program today. You traveled here to Kansas City for your first delivery. Where'd you go for the other 3?
So it was kind of interesting because actually when I was pregnant with my first, I had a family practitioner who was my doctor, but there were some OBs available at that time. But I obviously, being my first, I wasn't very educated on what I needed. So it wasn't until after I had the DVT that then things became more serious. The 2 that I had after my first, I still was on Lovenox. They were still considered high risk. But there was a high risk OBGYN here in Garden City during that time. She actually had worked with Dr. Parrish before, who I worked with during my first pregnancy. And so I was really comfortable in her working with Dr. Parrish to take care of both of those deliveries and those babies and my care during that time. And she did a phenomenal job, and I was able to, it was amazing. I went to the hospital that was 5 minutes away, delivered the baby, and went home. And so it didn't become really serious again until I was pregnant with my 4th. And she was no longer in practice. She is doing something totally different now. And the clinic that she worked in had gone from having maybe 5 or 6 OBs down to 1. And from what I understood, that one was very overworked and a lot of times wasn't available to do the deliveries because it might be some random doctor who was traveling in that would end up doing your delivery. And for me, being in the situations I had been in, with my 3rd, she had the cord around her neck 3 times. And because I had a high-risk OBGYN, she noticed right away that was an issue. She was able to have me stop. She was able to cut the cord and safely get the baby out. But those are things that a doctor who hasn't worked with you or hasn't seen a lot of those situations isn't going to be able to recognize. And that baby could have died. And so going into my 4th, I knew that I couldn't risk my health or that baby's health in knowing that it was really an unknown of what I was going to get. And so reached out to Dr. Parrish at Health Systems and said, I want to come back for this 4th baby. And he actually, we did everything we could to try and find someone to take on my primary care during the pregnancy and just do the delivery at Health Systems. That didn't really work out so well. And so I did travel to Topeka for most of my appointments. And I did have a few ultrasounds at the hospital to check in on baby during that time. But even the ultrasound tech at that time told me that over the time she had worked there, other than a few traveling techs, she was the only one providing that service.
That's got to be really frightening. You really had to have a good community. Let's turn to Dr. Parrish for just a moment. Dr. Parrish, what is it like trying to do this across a long distance, especially if there's no other physician there to help you on the other end?
very difficult. In a fight with one hand tied behind your back is a great analogy. But fortunately with Jennifer, because we had experience with each other from the first pregnancy, she was and had gone through it in her next 2 pregnancies. She was well versed in the things to be monitoring for, and she was such a good advocate for herself to ensure that she was getting the care that she needed, that she was reaching out to local folks there in the Garden City area, trying to advocate to get the care that she needed, so that she didn't have to travel to Topeka or to Kansas City for her routine prenatal care. Unfortunately, as Jennifer pointed out, that wasn't possible. So we made the best of it and pieced things together with resources in the Garden City area and phone call communications between myself and Jennifer and those providers that she had seen in the Garden City area. But it took a lot of effort to make it happen, and a lot of traveling for Jennifer.
Yeah, that's a really major challenge. And I'm going to talk to Dr. Parrish and Dr. Kennedy, Dr. Kennedy and Dr. Mosier for just a moment. Family medicine physicians used to do a lot of OB care, but sometimes they don't do as much OB care. Is it stress? What is that?
It's a little bit of stress. Again, as I mentioned earlier, the volume of care and keeping your skills fresh. It's your support staff to support you in the care that you provide. But it is stressful. I delivered babies when I was in practice out on western Kansas, 80 miles away from Mrs. Cunningham. But it was challenging because we didn't have anesthesia locally, so that added to the stress. You had to be monitoring a little bit more aggressively to recognize when problems were developing so you could have the time to intervene. So I think it's the stress of that. It's the low volumes in some of those communities are still trying to keep that service alive. But now as more are dropping that service, it falls to those who are remaining to take on that added burden, with the fact that now they've got patients who are traveling 60, 90 miles to get care. And it's inherently, challenging because the patient, if they go in once, to be evaluated 60 miles away because they're having labor pains, they think they may be in labor, they find out it's false labor, they go home. Well, the next time they may wait longer at home because they don't want to waste that 60 miles in 60 minutes travel time. The child care they have to arrange for, maybe time off work, all of those barriers. And so now they end up delivering somewhere along the road or in a hospital that hasn't delivered obstetrical care in who knows how long.
Wow, so Dr. Winnicke, this has got to be contributing to the maternal mortality and infant mortality rates in the United States. Talk to us a little bit about that.
Well, I think there's a lot of factors that are contributing, but we do know that the longer a patient drives, they have a higher risk of higher morbidity for the mom and then infant mortality as well. So it just makes sense that it takes longer to have someone intervene. As Dr. Mosier said, you might stay home longer. Perhaps you don't have those specialized services and might not have kind of an insight into a potential problem. But it definitely is definitely related to the amount of driving time to the morbidities.
We talked about driving time, but you made a great point here, Dr. Stites. It feels so funny to say that. But
don't we call each other that at home?
Yeah, I guess so. By the way, just in case you haven't already figured out, to our listening audience, smarter, nicer, everything right there. So as you look at this, you mentioned it, the question about culturally appropriate care. So you could be right next door, but culturally, language-wise, and maybe concerns about being seen or found, it's like you're hundreds of miles apart. Talk to us about the impact, even here in Wyandotte County.
Well, I'm at Vibrant Health, and Vibrant Health is a federally qualified health center, and several of our tenets is that we provide culturally sensitive care, and we provide it in their own language. So we hire from within our community. We hire from within our community, but also promote within our community. Really work hard to establish that we are community partners and hope that the community feels that with us as well. So when our patients come, they are coming to a space that they hopefully feel very comfortable. And we feel as though we are trusted, and we hope that our patients feel that trust. So they have the impression, and we hope that we live that impression, that we can listen to our patients, we do hear our patients, and they feel heard.
And you guys all kind of work together on supplying some of those obstetrical care and maternal care at Vibrant, both of our family medicine group and obviously our OBGYN group.
Exactly.
Dr. Kennedy, you spent your life trying to help figure out how to deliver health care in rural Kansas. This is your life's work. What are we going to do about this maternal care crisis?
Oh man, we got to find people who are willing to take the charge. You know, what's happened, I think, is times have changed a lot. Dr. Mosier was talking about this. You know, I also 30 years ago provided OB care in a town of 2,800, and we felt it critical that we could provide a C-section in an emergency, and so I got training to do that. That is harder and harder to do in today's environment, is to get family physicians who are broadly trained in obstetrical care, and then to establish partnerships with high-risk OBGYN and maternal fetal medicine. Those are all real tricky in today's environment. And then the other thing is, residency programs are no longer emphasizing the training in obstetrical care. And so as a consequence, when I trained, 25% of the family docs were coming out delivering babies, and now it's down to 9%. So what do we do? Well, I think one of the things that's happened is nationally, there's been an increase in rural training programs in family medicine. Many of those emphasize obstetrical care and the ability to provide a C-section when needed, and then identifying students early on. As I went through this and we studied many aspects of this, students who decide to do this, actually physicians who decide to do this, decide when they're a student. And so you have to latch on to them then and say, you know, you got the right stuff, and we need to hold their hand and walk them through. And the other thing that's been really successful in Kansas is loan repayment programs. And I think if you really energize those loan repayment programs so that there's a premium if you provide obstetrical services, then I think that may also help. But the hospital environment is critical. And so I think we have to build partnership across academics, across all the government agencies. We have to partner with hospitals and really come up with a statewide plan that looks at all the aspects of this and joins together to solve this problem. It's a huge deal. When I was looking at the data, the babies that are born to women in the maternity deserts, the neonatal mortality rate is 7.5 per thousand.
Yeah, that's crazy. Well, let me turn to Dr. Winnicke.
In non-deserts, it's 5.5 per thousand.
Yeah.
So it's almost 50% more.
Which is not acceptable. So Dr. Winnicke, as you look at this, talk to us a little bit about a role of a certified midwife that you mentioned.
Yeah, so I think that, and Dr. Kennedy mentioned, I believe in 2013 when he looked at the first data, there were no certified nurse midwives in rural Kansas. We do have certified nurse midwives in Kansas, but more in the urban areas. I don't know, I do know a few are out more in the rural areas, but I don't know the numbers. But midwives have different levels of training, and we're talking a certified nurse midwife, or so they were a nurse and they have extra training, they get doctorate level training, and are trained to deliver antenatal care, delivery care, and postpartum care, as well as reproductive health care. So there are some states that are using midwives, or really advocating for midwives to be in some of these more rural areas. I am not sure of our current count in rural Kansas. Maybe Dr. Kennedy has a current count. Maybe, I don't know.
Not since about 5 years ago. The current count was there were 2 in rural counties, okay. And they were working with. One was working with a family physician. One was working with an obstetrician.
I think there are probably a few more that are not certified. As I mentioned, there's sort of levels of midwives, so there are CPMs, professional midwives that don't have that same sort of training, but I do suspect that there are some other midwives out in rural Kansas practicing.
So I want to just engage the two of you guys for just a second. We've talked a lot about the rural area. We focus back on the urban area. What can we do to make sure places like Vibrant or the University of Kansas Health System helps provide culturally appropriate care so we don't have effectively a desert right here in the middle of our own community?
Well, I think we continue the partnership that we already have. We are very fortunate to partner with Dr. Winnecke's department. We have high-risk OB providers who are part of your department but spend time with us, and that makes high-risk OB available to our patients. Our patients otherwise would not have access to the high-risk care that we are able to provide and share.
And you also partner with a family medicine program too.
And we also practice with family medicine who provide low-risk OB for our patients as well. Vibrant is uniquely situated just because of that. We are able to provide care to folks who would not otherwise receive care, and it doesn't matter to us whether they can pay or not, and yet we have access to this high-risk care and low-risk care throughout our community. Our patients feel comfortable coming to our space, so we are grateful that you guys feel comfortable being in our space to provide that care.
Yeah, that's a pretty powerful solution, but hard to affect in all these rural communities. Impact of telemedicine. Talk to us a little bit about that. How can that help with this?
Yeah, telemedicine can certainly help. We found that with the CARE collaborative work with providing telebehavioral health across 11 of our rural communities. And people have certainly got a lot more used to that during and post-COVID. So we can offer those services, save one of the barriers to specialty care, which is distance and time away from the local community for our patients. So it's getting the partnerships developed, because one of the things that we tried to make sure with our telebehavioral health was that when we had an appointment scheduled, a time slot, that the patient arrived and the provider was there, and so they connected. So keeping those slots open is important, because otherwise a provider could be doing something else. They could be seeing live patients in their clinic. So it's really challenging how to set that up, how to make it work for both the patient and the provider delivering care via telemedicine. But I certainly do think that that will be a long way to solving some of the issues, to support some of the providers still out there delivering care and trying to deliver high quality care to impact outcomes.
Yeah, that'd be awesome. And Dr. Parrish, you're doing this. Are you still doing it across the state in other areas?
We are doing it in certain areas. We would like to expand even further out into western Kansas, and I know that there has been discussions about that happening. It just hasn't been fully implemented. We're as far west right now as Great Bend, providing those type of services, but we'd like to expand to other areas in central and southwest and northwest Kansas as well.
Yeah, that sounds like an outstanding alternative. All right, this is a pretty amazing program so far that we've talked about. Now, after giving birth, there's a whole discharge process. What kind of discussions do we have to make sure that discharge is safe after a delivery?
Well, I think it depends on where the patient's coming from, and perhaps what their medical comorbidities are. So what we frequently try to reach out to their provider back in their rural community, or their community, even maybe not even rural, could be a bigger city in Kansas, and see if they can follow up with them there at least 1 or 2 times, or have a place that at least that clinician knows what happened during the delivery. So if they need something immediately, they could reach out, but try to make them not have to come back to the University of Kansas if they don't need to.
Yeah, that sounds great. Jennifer, does this sound at all reassuring to you? Do you feel like this is a step forward in what we're trying to accomplish here?
I hope so. It's hard to know, right? I mean, it's one of those things that I hear on a fairly regular basis. I actually just sent an article to one of those I was working on prior to leading up to this, a letter to an editor that another female wrote to our local newspaper about a month after I had my baby, titled These Maternal Deserts, and discussed kind of what her experience was. I work with another female who 2 weeks ago drove to Wichita to deliver her baby. It's just one of those things that until I see some more local action, I think we have to recognize that places like Garden City, we are the regional hub for everything. This is where people shop. This is where they come to do all of their care. And if we can't provide those basic services, we can't continue to survive in general, because local professionals who are lawyers or other doctors or other professionals, they aren't going to choose to come and live here if they can't even have a baby here.
Yeah, no, that is a powerful, powerful message and point. Okay, this has been an amazing program so far. We're going to go into some of the questions section. We want to answer those questions, so send us your questions. Send them into the info on the screen. Includes using the chat on YouTube, Facebook, the X platform, or emailing the Medical News Network. Dr. Dana Hawkinson is now going to join us with a COVID count. I think he's out in the Southwest Kansas City market, Olathe Medical Center. Hawk.
Yeah, we're out here. We're out here all week and next week too, so it's good. It's good practicing out here for sure.
Awesome. What's our count like today?
Yeah, the count a little bit up. 12 active patients in the hospital with COVID. We had been down in the single digits. Hopefully we can get back to those single digits in the next couple weeks as well. And we would say that overall the respiratory viral trends around the nation are decreasing, especially when we're talking about things like people going to doctor's visits for respiratory infections. And then, of course, the specific diagnosis of influenza. All of those things are down nationally as well. So it's looking good on that aspect, but hopefully we can get the numbers of inpatient active COVID patients down as well.
Absolutely. Now, you saw a new study asking pregnant women, so this is very topical, pregnant women how confident they are in the safety of COVID vaccination. It was published in JAMA Network Open. It compared surveys from 2021 and 2023. Sounds like the confidence is dropping. Talk to us about that.
Yeah, this is unfortunate. And I think I could be extrapolating and just understand that this may be going across all vaccinations. This was a study specifically looking at COVID vaccination, and like you said, 2021 and 2023, so 2 waves. The respondents were asked in 2021 and then in 2023 again what their confidence is on the safety of the COVID vaccine. Again, it is a small study, but they really tried to get ethnically, linguistically, and racially diverse groups in this respondents. So initially, 77% of those people had received a COVID vaccine, so the vast majority did. But what they found was that from 2021 to 2023, across all of those groups that I mentioned, unfortunately, the confidence that the COVID vaccine was safe, decreased 25 to 30 percentage points. And so that is a concerning thing. And again, I would say this probably isn't just for the COVID vaccine, but we may be able to extrapolate that out to other very important vaccines to keep mother and baby healthy. And I think that's why it is certainly important to try and facilitate, and we have the ability to do it, we just need the means, of course the people above us for sure, to facilitate those providers going out to those areas that need the help. And it isn't just the rural, but it is the urban areas as well, just as if we heard our guests talk about. And then once we can do that and facilitate that, we can certainly try to further encourage and increase access to care, but also this day-to-day education, explaining and showing how these things are transparent, the safety and the efficacy of not only vaccines, but other aspects of care as well.
Yeah, but Dr. Stites, have you seen this kind of loss of confidence in vaccination at Vibrant too amongst populations?
Not as much. One of the tenets of federally qualified health centers, and we say this a lot at work, is we vaccinate. We vaccinate, and we vaccinate all people. So I really haven't seen that decline in
this
COVID
year. That's
this
good
year
news.
in particular.
'Cause I'm not sure this is always consistent all the way across the country.
No.
What about in your personal view?
I haven't read this. I haven't read the study, so I can't comment directly on the study, but I don't think we've seen it as much. I think it's probably a little bit, frankly, of maybe our clinicians, when things were really bad in COVID, it was really easy to use that as an explanation to talk to your patients.
Yeah.
We don't have some of those examples that are fresh in our mind anymore, and I think that perhaps we aren't as, maybe our counseling to patients is changing a little bit. Because in 2021, we were seeing some pretty bad outcomes in pregnancies.
Right, without vaccination.
Right.
Yeah. So that's
You know,
changed a
and
little
fresh
bit.
in mind things are easily rememberable. So again, I'll have to pick up the study. I've been in the Lancet articles this week, so I will pick up the JAMA article after clinic.
All right. Alexis Del Cid has been watching from questions from our community. Good morning, Alexis. How are you?
Good morning, Dr. Stites. We have plenty of questions coming in. This topic has definitely struck a nerve. Jeremy has a question. He wants to know if the maternity desert problem mostly affect births, or does this also hit hard on care leading up to and after the birth?
Ooh, Dr. Mosier, I'm going to guess it's all the above.
It's all the above, yeah. You could imagine if you don't have someone readily available, comfortable to go to, or have an established care with them to do preconception care. You make sure you're as healthy as you can be before you decide, to have a child, if you can. The care during. Sometimes we've lost that connection where the rural communities no longer delivering, or not even delivering prenatal care. So all of the care has to go regional. So that's an added burden to the patient as well. And then postpartum. We definitely need to have a more standardized, evidence-based approach to discharge, and make sure that everyone that could come into contact with that individual is aware of what issues they need to be looking for, and familiar with managing postpartum care. But now where they're going 60, 90 miles back home, where they may not have providers that are engaged in that type of care or aware. And so we have some work to do, I think, to kind of have a regional collaborative approach to providing maternal health care.
All right, Alexis.
Ruth Ellen has a great question. Ruth wants to know, are there any mobile medical services with specific training in rural areas?
I don't know the answer to that question. I'll look at Dr. Kennedy.
So at one time, there was an attempt to try and establish a rural well car, and that was a satellite-linked clinic on wheels, and to try and go to areas where healthcare was, minimal, and it, it's not a viable economic model, and so it never did really take off. There's been a few other programs to try and put like healthcare students, nursing, medicine, etc., in and have them do little clinics, but their capabilities are limited, and really it was some screening clinics now and then, but nothing has really taken off.
All right, Alexis.
Jean wants to know, what role does telehealth play in alleviating these deserts? Can telehealth play a role in this?
Dr. Mosier, what are your thoughts? And I'll circle back to Dr. Perry. She's been doing it. We kind of asked this question a little bit ago.
Yeah, this kind of comes back to the model that the Care Collaborative is working with in Colby. We can use remote patient monitoring and care coordination like we've done with our chronic care managers to help support in between the clinic visits the patients back in their home communities, to just make sure that everything's going according to plan, whether it's blood pressure monitoring, blood sugar monitoring, weight gain, etc. And that the provider is getting that information in real time and able to act on it when there's a red flag that goes up, if you would. So, it's a mode of telehealth or remote health. And then, indeed, it all depends on what the local providers are comfortable with. If they are comfortable with doing FaceTime-like visits for those individuals, and they can gather the vitals locally, great. But it just doesn't work very well as you move into and through the OB care time frame. So it could. It will have a role. It is a tool. It just needs to be figured out how to best apply it.
Yeah. All right, Alexis.
We have a comment from our viewer, Ruth Allen. Ruth wanted to share, this is what Ruth writes: women health care in general is an issue in rural Kansas. A friend of mine had to go to Colorado for her care.
Ouch.
Yeah.
All right, that's not, we hear this really, people, when it comes to healthcare, state lines are not something you have to respect.
No, that's true. I was fortunate, the mentor I trained under in residency in Salina, Dr. George Marshall, his father was a GP out in Colby back in the day, and when I told him, you know, I'm back in my hometown, population 800, and I need somebody to come in to do, consultations, do an outreach clinic, and would you be interested? He loved to fly, so he came out once a month. We did an outreach clinic and gave resources to our local hospital, our community, and surrounding communities that we wouldn't have otherwise had. So it can be done, but again, you can imagine he's taking a day out of his practice to fly out and help me deliver care. Now, granted, that there was some reimbursable services for that, but not everyone wants to do that, add to the stress and volume of work that they're already doing. But that was a model that worked great for us for over 15 years.
Yeah, I think one of our challenges is that healthcare, great healthcare, has gotten very complex. It requires a lot of monitoring, it requires a lot of feedback, and I think that's a harder and harder model to export financially for a small number of patients.
Yes.
You've got to have some level of expertise, and I think if we don't, we've got a ways to go before we figure that out. Alexis.
Such a good discussion, and we're going to, I'm guessing, keep getting comments and questions throughout the day and the days to come on this topic.
Yeah, I bet we do. Dr. Stites, as I listen to this, and I am again struck that we've watched mortality rates rise in urban areas as well. Part of it's a desert, part of it is a lack of insurance. What are all the other major factors that you think that are helping cause that?
I think one of the major factors is that patients feel as though they're not being heard. They either aren't able to speak the language to the extent that they can make themselves understood. Sometimes it's that they feel the providers aren't paying enough attention. Sometimes they feel as though they're not being respected. And I think that plays a primary
role. Yeah, those are really, really hard things. Well, this has been an amazing discussion, and I think we could probably go on ad nauseum today. But I know we have to move along a little bit, but I want to hear final thoughts from everyone. Jennifer, first of all, I just want to say thank you. You're one of the best guests we've had. We're going to have you back, and you really have done a great job, and thanks for both your bravery in having children, but also in how well you've expressed your point. So final thoughts for today.
I think that where I would like to leave it is that there has to be some incentive, I think, and maybe it's some collaborative incentive that works directly with the community that is looking for the provider, and then the health system that is located in that community. Maybe they could work together, similar to like what we do when we're trying to build houses or bring businesses. We have these dollars that we use to incentivize these people. So if the same thing were true and we utilize those to bring doctors, I think we could make it work, right? Because even with lawyers in what I do, they're always looking for a way to get that $100,000 or $150,000 worth of student loans paid off so that they can live a little more freely after spending all of their time in education. And so I think this has to be a wider conversation. It can't just be about the moms who are having the babies. It can't just be about the doctors who are interested in doing the work. It really has to be with those outside people who have the ability to move things, to make them happen. And I think we have to hold them accountable to making those things happen. And at the end of the day, realize that our communities will not grow without this changing.
And I think your point about that was spot on. You talked about how can a community really grow and thrive without the right healthcare around it. Dr. Parrish, final thoughts.
I think the main take-home point is we still need to get providers out in rural Kansas that can provide this type of care to improve access for patients out there. But I do think telehealth can help to identify patients that are higher risk. And as Dr. Mosier was talking about, they may still have to travel occasionally to Kansas City, Topeka, or other more urban areas in order to get actual hands-on care. But those in-between visits, so they don't have to travel so far each time, are very valuable. And I think by being able to identify those patients that are higher risk, you can set up a plan and be prepared for those emergency type situations so that patients know exactly what they need to do if there are specific symptoms that they start to experience, or at least know to give you a call, so that you can help them to plan and get them to the appropriate type of care that they need immediately. And in those cases that you're fortunate that you can plan and prepare ahead of time, they can do like Jennifer did and relocate temporarily toward the end of the pregnancy, so that we can provide them with the best outcome for both mom and baby.
You bet. Well, thank you. So, Dr. Stites, are you going to come back to our program? How do you like that? Spot on, people.
We will leave that for home to discuss.
Oh,
but for my final words, I feel remiss in sharing that in the FQHC world, I need to share that we have community health workers and that we partner with Community Health Council of Wyandotte County, who provide maternal community health workers. And they are in our space. Our prenatal patients see them on a regular and consistent basis. And these community health workers come from the community and, again, are trusted community members. They listen, they hear, the patients feel comfortable sharing. And also the community health workers provide those resources that are outside of medical care that are so important to our community. They provide the resources to help with transportation, to help for food insecurities, to help employment opportunities. So I would be remiss if I did not mention that, and I will leave that as our final thought, and we can talk about our next visit at home.
Program. Excellent. Yeah, I got out. I maneuvered on that one. Thank you. Thank you for being on the program.
Thanks for having us.
All right, Dr. Mosier.
Yeah, thanks. I think I'd be remiss as well if I didn't mention, there's a lot of great work going on across Kansas with a public health approach. The Kansas Perinatal Quality Collaborative, along with, the Kansas Maternal Mortality Council and whatnot. But I think our health systems have to get engaged in the public health side of this. And the public health side has to recognize the challenges of being able to find the time to engage at some of the work at the local level. But I think better collaboration, better communication is an opportunity for some rapid improvement. And then taking the training like we've been able to demonstrate with the Care Collaborative, we can take that and help keep some of the skills up and fresh for some of those out there delivering obstetrical care, maternal care, and help with some of those challenges that can lead to stopping delivering.
Yeah, that sounds so good. Thank you, and thanks for being here today. Dr. Kennedy.
Well, I think we need better data, and so mining the birth certificates for data would really help some of the data deserts that we have. And then I would be remiss as being formerly in charge of the rural training programs there. We need to train more students and residents in rural environments where they can see models of care. They can imagine themselves practicing at that level in a rural environment. Right now, most of the training is done in urban environments, and so they don't get to see what life could be like practicing in a rural environment.
Yeah, such a big difference. Dr. Winicky.
Well, I think, first of all, thanks for bringing up this conversation. It's not as sexy as some of the things that are on these topics. I get that, but it's really important. And I'll just close with, I think, Jennifer's points are spot on. I think that's what we should always remember. But lastly, they put out a patient safety alert, and they put the top 10 patient safety concerns for the upcoming year. And access to maternal and obstetrical care is on the top 10 list for national concerns. And they didn't define rural access, but certainly we heard today, we heard rural access, we heard urban access. Access as an issue, and we're gonna have to work together with lots of people at lots of levels, not only in Kansas City, but Topeka and DC, to really be able to provide the care that people deserve.
Yeah, that's exactly right. So I just want to say a big thanks and a big shout out to all of our folks from the panel today, and what a great discussion this has been. Thank you to everybody for watching and listening. In this program we talk a lot about faith, hope, and science. I think this answers you. I think we kind of know the science. I think people have kept the faith. We need to provide more hope, and we need to provide more ways we can make sure that children being born everywhere have the same access to great care, and that a mom who's delivering a child everywhere has an access to great care. That's an important challenge that's in front of us. We're not going to let that conversation end today. We have a lot more to talk about. So stay tuned here on Open Mics with Dr. Stites and all of our morning medical updates, because remember, faith, hope, and science, together we can figure this one out.
He went to bed with leg pain and woke up to a leg that had doubled in size. I'm Alexis Del Cid. On the next All Things Heart, see the life-saving treatment that had him back on his feet.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.